Hello, thank you for joining us today on Matters of Substance. Hi, Jesse.
Hi, Carley.
For those of you who have listened before, I don't think we've had Jesse on the podcast.
I have not been on.
Okay, well, thank you for joining us. Today we have Jesse Sarowicz. He is our epidemiologist for Porter County Hub Coalition.
Well, thanks for having me. I'm the epidemiologist for the Hub Coalition of both Porter and Stark counties.
Yes.
I've been, at this job for just under a year.
Golly, it's
I
been
know,
that
it's been a long time, yeah.
Oh, my goodness.
It went fast.
It's been a little while, so I'm glad we finally got you out here today.
Yeah, it's about time.
Yeah. So, Jesse, I was hoping you might just be able to share with our listeners a little bit about what epidemiology is and how an epidemiologist does their job. So they have some kind of, ground for understanding why we're going to be talking about data as we move forward.
Yeah. So epidemiology is it's a population science. I think it's technically a branch of medicine, but I don't know if other branches of medicine would say that. It is... it's a study of what is upon the people, essentially, which is what the Greek and Latin roots break down to. Mm-hmm. But I would describe it as, population health science. What is afflicting a population, and what are the trends, and how do things like diseases and epidemics, how do they affect other population health and things like that? Mm-hmm. So in this context, substance use is often portrayed as an epidemic, and I think that's true. It is. We use data to show trends in things like overdose fatalities and associated infectious diseases like hepatitis and other things like that. Mm-hmm. And it's a way to, in the world of prevention, target interventions, essentially. So if we know people are using synthetic opiates versus prescription opiates, which is sort of a nuanced difference, but we can target more specifically to those things. Mm-hmm.
So like for us at Hub Coalition, that would almost equate to what programs are we going to use?
Right.
Is the way that we're going to educate the community? Are we going to put a billboard out about synthetic opioids versus prescription specifically?
Sure.
So that kind of informs how we move as a coalition.
Yeah, and I think that's the heart of epidemiology in general is how can we use our time wisely, essentially. You think about any sort of epidemic, obesity, gun violence, things like that. If we get down to the nitty-gritty of the specifics, we can point ourselves in a way that is going to be the most, have the most efficacy.
Mm. All right. Personal question.
Yeah.
Why epidemiology? What brought you to this?
Yeah. So I guess in my educational journey, I was at Michigan State University. I was studying physiology. My plan was, I'll go to medical school. I'll be a physician, and I'll do this, that, and the other thing. And what happened was, as I got into my later years, I realized that, I realized this, but also I had a lot of friends who were older than me who were going into medical school and starting medical school. And all the feedback I got was, if you really, 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 really don't love this, do not do this. Mm. And I found that I liked physiology and I loved science, but I didn't love the idea of medicine, I suppose, in the way that it is when you treat patients with drugs and work at a hospital and do surgery. It didn't feel like it was for me. But having this scientific background and knowing physiology, I was thinking of what are other moves I could do as a career, I suppose. Mm-hmm. And I found public health was kind of a mix of using scientific theory and knowledge, but also in a way that was more, for lack of a better term, social justice oriented. I believe public health is a social justice field, and I would think most people would say that. And when I was at Michigan State, so I majored in physiology. I minored in what a program they call history, philosophy, and sociology of science, which was a specific way to bridge humanities and sciences and, for lack of a better term, softer sciences together. And I think epidemiology does that a lot, and so does the field of public health in general, is that there's a lot of social problems out there that really determine health. And I think, in my opinion, that healthcare should be moving in that direction of addressing social problems and geographical problems and social disparities as a function of treating people for illness.
Well, that makes sense.
Yeah.
I completely follow what you're saying in the sense that, like, we talk about health disparate populations in our communities, and we know that, you know, depending on what group of people you belong to, whether we're talking, you know, our race, our ethnicity, whether we're talking about age group, whether we're talking about maybe just demographics of where you live or the geographics of where you live, you can be presented with different things that occur within your community. Yeah. And so if we don't know those things when we're trying to provide treatment or care for somebody, then we're probably not going to do our best job. Right.
Well, and because a lot of health disparate populations are also marginalized communities, people of color, people of different sexual orientation, they are often seen as, especially in the field of substance abuse prevention, it's seen as a moral failing rather than a social problem. So, you know, we see higher rates of substance use in marginalized communities, and that's not because there's a moralistic failing. It's because of how history has gone throughout every year we've ever been alive. And I think that's where public health comes in, is we can sort of start to justify the disparity that has been created by being in a society.
No, I totally get that. When I was taking my, I did a certification in public health, which was called the addiction intervention course. And one of the things we talked about was like the history of like peer groups, so like AA, NA, and just kind of like going back deep into that. There was even like some really serious things that were done that were harmful to the population they were trying to serve. You know, it was pretty tough. And so I just understand. I understand how important history is and how it affects, you know, currently how people recover or how they're exposed to things. You know, we know with the tobacco industry, and we're seeing it kind of mirrored in the marijuana THC industry. You know, they specifically targeted people who were in lower socioeconomic places. You know, and now if you look at some of the states that have legalized THC, you'll see that there's far more dispensaries in those same areas. And it's just, you know, history helps us understand and have knowledge and power on how we kind of shift and make changes for people in a better way. Right. So.
All right, and that's where the data comes in my opinion, is we can say, you know, till we're blue in the face, poorer communities are affected more by this. And when you have data that actually shows that, I think that really makes your argument much more, I don't know what the word is, powerful, I suppose.
Sure. Yeah, I'm a fan of data.
Yeah, you and me both.
Probably you a little more than me.
Yeah, yeah,
But definitely, you know, data is important because, like you said, it informs us. It almost gives like validity to what we say. Like we can observe something and say, oh yeah, I see this. But if you have, you know, 100 examples of it and people are saying this happened to me and here's 100 examples that are written and tracked over a couple years, there's no really dispute whether or not it happened. Right. So yeah, data is super important. Can you share a little bit with our audience about how you use data to help us inform what we're doing in the coalition?
Yeah, a lot of my role is working on an epidemiological profile, which shows trends in our county of different substance use variables, fatal overdoses, emergency department visits, non-fatal overdoses. A lot of it is public data that shows just behavioral trends, things like, are you a current smoker versus are you a past smoker, that kind of thing. And we use the data to kind of hone in on what key target areas are. So, for example, I think we use the Indiana Youth Survey to talk about adolescent substance use. And if we look at certain groups of substances like stimulants, like cocaine or benzodiazepines and things like that, we're noticing that it's not a significant portion of the adolescents who are using these things currently. I think it's as low as 0.2% in some areas. Whereas if you look at rates of vaping, nicotine, vaping marijuana, it can get up to almost 25% of the students who participated in this survey. So to me, that tells me, well, if we're going to be working on preventing any substance use in adolescents, we should probably be focusing more on vaping versus cocaine use, prescription drug use. And that sort of saves us time, where we could go in and we could try to prevent every substance ever for adolescents. And while that I think that would be a good thing in theory if you had the time and the resources for it, those things are limited. Mm-hmm. So we might as well put in time to something that's affecting more of the population versus the one or two students who are doing them. And that's not to say that those two students get lost in the cracks, but epidemiology as a field is a population-based field. So we can't really get hung up on one or two cases of something, which is sort of the push and pull of the field. Because I know everyone in prevention would bend over backwards and use every minute of their life to prevent any substance use. Mm-hmm. But when it comes down to it, again, our resources are limited, so we should be focusing on things that affect a lot of people versus less.
Mm-hmm. Yeah, I think that's so important that we have that scope, though, you know, because you're right. People in prevention, like, we lead with our hearts, right? It's like, I just want to help everyone, and that's a lovely sentiment. And I think that passion is important when you're doing the work, but yeah, we have limited resources.
Right.
100% correct on that. Limited resources, limited time. We have to focus in on what's going to be the bigger impact. Hate to say it 'cause it sounds kind of like, I don't know, I guess maybe overused, but more bang for your buck, if you will, you know? I mean, we just have to do our best with our resources.
And I think, and that's for just things that are targeted specifically at specific substances. I think when it comes to what we call risk factors versus protective factors, which are attributes of a person who it will either set you more at risk for substance abuse versus protect you in a way against substance abuse. Those things often are behavioral, and they're social, and they're cultural, and that affects every substance. So I think a lot of prevention work is on those sort of protective things to make sure that if we're addressing a lot of social problems versus just marijuana cessation, we can cover a wider scope of people. So the students who are using prescription drugs, or misusing prescription drugs, I should say, they might also get a lot out of something that is setting them up for success socially at school, which might have been designed to prevent marijuana use or might have been designed to prevent alcohol use. It still might catch them in the cracks.
Yeah. Well, it's like when we talk about coalition work, a lot of times one of the things that we do is we try to have youth leadership committees or groups within school systems or within our county or city, however that coalition is kind of identified. And we do that. We have a leadership group because, one, we can incorporate those substance misuse prevention measures, but it is a protective factor in and of itself.
Yeah.
To let youth have a group where they're learning, one, great skills, two, building social connectivity, three, especially if it's in a school, having some connection to your school. Connection to the community is a protective factor. So it really hits several protective factors just by hosting one group. While they may not say, oh, our purpose is substance use prevention, that might not be it. We're still doing prevention just by hosting that group,
Yeah.
which is really kind of cool if you think about it.
Right. And I think that hits down to the key of what prevention and intervention are kind of what they share at the core. Where like a tobacco coalition and our coalition and maybe a coalition for mental health, they would all have the same sort of key understandings of these social factors. And I think in grad school, it wasn't a thesis. It was like a thesis project in a sense. It wasn't as long. It was all about recovery capital, which is a theory in recovery that it's essentially the sum of all your real and perceived assets in your community, which could be people, it could be mutual aid groups like NA or AA. And it could be having a job or having an income enough to live in a home and that kind of thing. And it is ubiquitous for all substance use disorders in general. Whereas, and it may be more effective for alcohol use disorder versus marijuana use disorder. I didn't really get into the nuance of it because I think it's a pretty new idea. Don't quote me on that.
It's been around for 50 years.
No, it's definitely not been around 50 years. It's like maybe 10, maybe 15. But I did this project on it using a population of men who were in recovery. And the project essentially was the longer you're in recovery, you should be accruing this recovery capital. And there's a way to quantitatively determine a score, if you will. And the findings were that, the longer you spent in recovery, the more you accrued this capital. Essentially, you made more connections with people. You probably stuck to a mutual aid group. You likely found you a job. You had a support system that you previously didn't have. And I think that kind of theory works everywhere in prevention. So all that is to say is, I think the key things that are really important are, those social connectivity things. And when you bring it down to adolescents, they're at school for so long. It's essentially a second home. And often it's, in extreme cases, it's often a safer place to be. It's often a place where you can feel accepted versus at home where maybe something is not going well for you. Maybe a parent is out of the picture, or maybe there's domestic violence at your house, or maybe you are homeless. Addressing those things in and of themselves, I think helps solve a lot of health problems, including risk for substance use disorders.
Yeah, it definitely does. I think when we talk about school, that's kind of the trick, right? I feel like, and I guess feel isn't the best word because I know that, trauma is perceived differently, right? So like for not just trauma, but our experiences are different. So for me, I could go to school and that could be my safe haven, or you could go to school and maybe you're getting bullied there. So now that's your risk factor. It's such a challenge because home could be a risk factor or it could be a protective factor, It's so different. And when we talk about prevention, it's like you kind of almost have to identify, if we're talking about prevention at a large scale, we have to identify how the majority feels. Right. But it's also really important to have services for the individual too, right? Because we talked about how, epidemiology is more of a globalized kind of concept, more large scale. But, as prevention efforts go, you also do sometimes have those like, okay, so how do we connect people with counseling? Something really cool we have on the horizon right now is called Handle with Care. It's currently in some communities here in Indiana. Us here in Porter County, we're trying to implement it into 2 different communities. We're really excited about it because the basis of Handle with Care is basically if a student goes through something that would be considered traumatic from the scale of ACEs, adverse childhood experiences, is kind of how we're gauging it. If they went through something that's traumatic, law enforcement then contacts the school. They keep it very confidential. It's just a name and Handle with Care. Then the school people know, okay, if this person didn't bring their homework, or if they're falling asleep today, or If they're having some kind of outburst, we know that something happened in their home and they're struggling and they just need a little bit of a break. Or maybe it's, hey, something happened and they're getting really angry. So they're obviously having a hard time regulating emotion. We need to send them to the counselor today in the school so that they can get them connected with resources. So for me, that's almost like while we're doing that at a large scale, we're providing it to two communities. It's almost that individualized piece of prevention, ideally. Yeah. Because once again, if we connect them to the school, we're doing a protective factor.
Well, and I see my role as epidemiologist is not necessarily to help make those decisions, but it is to help inform the trends and what's going on. And we saw that there's a need for students who would likely need mental health counseling or are having these adverse child experiences in their homes. And, you know, you can find that, like, there's an index for that. And if you see, well, it's higher in this area versus others, it's higher in this school district versus others, you can individualize your target approach, if you will. So, yeah, I see my role as not necessarily a decision maker about what's the best way to serve these populations and what's the best way to serve these individuals, but it's to identify trends and problems and use what we know scientifically and statistically to actually put that into like practical care.
And I think today it was a great example. So if you are here in our community, we have a coalition meeting every second Thursday of the month at 9 a.m. Nope, sorry, scratch that, 8 a.m. at the Porter County Community Foundation. And the purpose of the coalition is really to determine what the data says and then make shifts within our community, whether that be educating the community, providing prevention strategies, doing intervention, whatever that looks like. That's what our coalition works to do, with the overall goal being to reduce incidences of substance misuse as well as educating the community. So we had our meeting today, and it was really great because Jesse was able to come in and share basically the trends that we see here in our county currently. And that, I think we had really great conversation surrounding that, right?
Yeah, we talked a lot about the kind of data that I'm using to capture the trends in the county. And we talked a lot about how these trends are seen and manifested at sort of an individual institutional level. So there's all these people representing multiple different sectors of prevention. There's recovery and there's other coalition representation and that kind of thing. And when, I can say something like 18% of adults in Porter County were smokers in 2022. That's a statistic that's nationally collected and has been reported. And I can say, well, it hasn't really changed over the past 5 years, and that's true. It's been sitting around 18%. And this didn't happen. I think that's just how it is. But had someone from maybe a smoking cessation part of the prevention sector said, well, I don't think that's true. I think it seems like more people are smoking, and maybe they're capturing the data wrong. And we get to have that conversation of, the data says this, and we can only say what the data says, but also there's a community knowledge that isn't reflected in data at all. And I think we get to have this interesting conversation of, well, I'm saying this statistically, and you're saying, well, I think that's an underrepresentation. And then from there, we get to work off what we think is best for the community. So it's a give and take, and I don't think it's, as much as it'd be great to have all statistics be super accurate all the time, sometimes they aren't. So, for example, I use a lot of state data dashboards for my profile, and they can only report data that they've collected from these smaller institutions. So when I report things like emergency department visits for non-fatal overdoses, I have to assume that every non-fatal overdose that happens to go into an emergency department is reported to the state, and that's not necessarily true. And I don't even want to say if it's necessarily true, but we have to operate under the data that we have. So it's interesting to marry these two ideas that sometimes statistics can be underrepresented, underreported, and we have a finger on the pulse of community members who work in the community, but also people who live here, people who see what's going on, and they talk to individuals, and it's kind of a meeting in the middle of global statistics or statewide statistics and personal experience. And I think that is kind of the sweet spot you want to be in.
Yeah. And when you bring up opioids specifically, like the reduction of non-fatal overdoses, first thing I think about is we know that we've expanded harm reduction things here in Porter County. I'm sure we have coalition members who are in different agencies, obviously, and they've done things and we've done things. But specifically, we have something called the ROOT Committee, which is Reducing Opioid Overdose Together. And in the last month alone, I know that we've given out 60 doses of Narcan.
Yeah.
Right? So they're being given out because they're getting used.
Right. Yeah. I mean,
so we know that there's probably some non-fatal overdoses that occurred that maybe we haven't captured. But we don't know what those are.
Right. And and the best you can do is record those 60 doses that are given out. And I guess to be pedantic about it, you could say, well, someone probably grabbed 3 and maybe haven't used them yet. But that's not really the point.
Right.
And it's not really a hill to die on either to say, well, we need to know who's using Narcan versus who's taking it. If people are taking it, it's doing its job.
Exactly. I mean, it's a life-saving medication, and if it saves a life, perfect. That's exactly what we're looking for.
Yeah, and if that's not captured in any data set,
the life is still saved.
Life is still saved. And, in a perfect world, it would just be recorded by magic and then everyone would know it.
A little magic in the world wouldn't hurt.
Yeah, I agree. If of those 60 doses, if we knew 55 of them have saved lives and 5 of them are still in someone's purse waiting to be used. Or, I guess it's possible they're in the trash can somewhere, but I think you have to have faith in people too, that they're not taking it to take it. They're taking it because they think it will help save someone.
Yeah, I agree. And I really think if you work alongside or in the harm reduction community, you really kind of understand with harm reduction, it's people who just care about people, right?
Yeah.
I mean, I work, well, obviously we do some harm reduction strategies, but also working with people in those other agencies. I mean, that's it. Like, they just want people's lives to be saved. They just want to make sure people in their community are safe and have resources. And so I doubt, I'm not saying it's not impossible, but I doubt that people are just taking it to take it.
Right.
Usually I think it's people who are like, I know what this is and I know the value.
Right.
And I'm going to use it if I have to.
And I think where the data comes in again is if I know there are 60 doses that are taken, I can reasonably conclude that there is a need for this. And if we're tracking it by monthly, which we are, if we see it, increase year to year or month to month, that tells us a lot of information about spatially, where are people needing Narcan and, how much do they need? And I think that's really interesting, especially because, so you marry these ideas of, when we talk about using data for targeting intervention, a lot of that is what's called primary prevention. That's a way to stop substance use before it even starts. Whereas I believe harm reduction is secondary prevention, meaning we're trying to stop you from dying from this epidemic, essentially. And the data works in both primary and secondary prevention. On one hand, we knew that people were overdosing at high rates, and Porter County has a high vulnerability, especially for opiates. We used that data to show, well, we need Narcan naloxone boxes available to the community. And now we have, how many?
I think it's 16.
16? Yeah. So we're doing that, and we saw that, and now we can also work on stopping people from ever, developing a substance use disorder or hopefully misusing it, or using it at all, which is misuse.
Yeah, right. And I'll say, I mean, one thing I always love to say, I say this a lot when I'm out there in the community doing booths and things like that.
Mm-hmm.
And it's interesting. There's almost like a stigma that's associated to Narcan. You'll have Narcan out on the table. Somebody will grab it. You'll explain what it is. And they kind of, oop, I don't need that. And they put it back down. And one thing I always try to make sure people understand, it's for everybody.
Right.
I have family members who have opioid prescriptions, and they take their prescriptions as they're supposed to, but that doesn't mean that they don't occasionally forget if they took one in the morning,
right.
Or several hours ago, and they're not ready for that next dose. There's a risk to overdose in that situation. Right. Think of your older adult community. Are they taking their medication exactly as they should every single time? Maybe not. Maybe so, maybe not.
Sure.
Depends on the person and their health and all of that, right?
Right.
And so it's just good to have, because you don't know who's going to need it. No matter who it is, it's a life-saving thing. Let's keep it on us, because whether you have come across somebody that you don't know and they seem to be having an opioid overdose, or it's your grandma, it's still going to save a life, or can save the life.
Yeah, and that highlights sort of a gap in the data infrastructure that I have currently. Is we're talking about fatal overdoses or even non-fatal overdoses of prescription opiates versus synthetic opiates versus heroin, that kind of thing. Data dashboards will say, X number of people had a fatal overdose this year in Porter County, and you may be able to get an age breakdown. But it's likely that you're not going to get an age breakdown and also a breakdown by substance. So I could tell you from a state maintained dashboard that people who are 65 plus are dying at an elevated rate of prescription overdoses, of fatal overdoses of opioids, but I can't tell you if they're prescription or if they're synthetic, or vice versa. I can tell you that people are dying at higher rates of prescription overdoses, but I often can't get their age breakdown. So currently, we're sort of limited by what is available, and the coalition staff doesn't necessarily have the manpower to go out and collect all that data.
Right.
So
if you don't know, it's only 4 of us.
Yeah.
We got a county of like 168 or something.
175,000.
175,000.
I can give you the exact number. Hold on. It is 174,791 estimated by the American Community Survey of 20. Yeah. So that's a lot of people.
And we're 4.
And there's 4 of us. And data collection is not easy. It's nice that there's a lot of state funding to keep these dashboards open and stuff, but it's often leaving gaps in a lot of things. And again, it's not magic. If everything was magically recorded, we would have all the problems solved. I would hope.
Yeah, right.
But even then, coalition members in their work go, well, I want to know more about how this breaks down in the county, or I'm working with adults who are 55 to 70, or I'm working with adolescent black boys between 16 and 24. How does the substance use break down for them? And the short answer is I can't tell you, because there's gaps in what we can collect. And we could go out, if we had the manpower, and collect surveys of every adolescent in the county, but that would take so much time and so much effort. And it's honestly maybe not even worth it necessarily. I don't know. Yeah.
But I wish, and for those of you listening, if you've got any solutions, you can always reach out to us on Facebook or give us a call.
Right.
219-280-5252. But I would really love to see us get more data, especially local specific data from agencies in our community, people in our community, it's tough, and it's great that there are state and federal dashboards. You know, wonderful that we have access to those things. Indiana Youth Survey, super beneficial for us. But it would be great if we had like something that was a little more, just that push above, where it's like we can get a little more identified in our data. Like, okay, yeah, we can see that, you know, people who are 65 to 70, they maybe don't get out of their home as often. And so we're seeing that they have been using alcohol at a higher rate than people who are in their early 50s. You know, I mean, that's not an actual stat, so don't quote it. But, you know, would it be nice to have a little bit of a breakdown of that age and understanding of the substances that are that specifically we should target in those age groups? Yes, absolutely. Right. That'd be cool. Yeah. It's a dream.
I mean, all data is good data. Well, I don't want to say that as like a as like a true statement, but more data is better than less data. How about that?
Yeah, I like that.
Yeah, and I think that's the thing. That's part of my role too, is to sort of set up this infrastructure of data sharing, and you know, all of it might not be cohesive if we put it all together, but trends can be shown in multiple different sectors of multiple different people. And if we can compare these things and see them year to year, especially for breakdowns of, you know, race and age and sexual orientation, we want to make sure that groups are not being left on the sideline. So you could be told like people 18 to 25 are smoking more marijuana than they are, you know, using cocaine or whatever. But it's possible that, you know, maybe it's people who are 18 to actually 20 that are using it at way higher rates than, you know, 21 to 25.
But they're just in that category.
Right, and it's just one category. And it's a lot of idealistic thinking, because when you really get down to it, like breaking down data like that and collecting it upon your other work that you're doing, that's hard. Like it's why it's usually, you know, full-time jobs for people. You know, and I'm very blessed to be an epidemiologist, and I love this job. But if someone told me that I had to go collect all this data by myself and also provide treatment for people, I would be doing two jobs. So I think we are at a meeting of, on one hand, we want these providers, these recovery providers, these mutual aid groups. We want to know who's participating. We want to know who is getting what services. And we want you to collect that and send that to us. Yeah. But also, you have to keep doing the regular programming that you're doing. And that's hard. Especially because, you know, I think we've talked about implementing, you know, surveys and focus groups. And, you know, we are doing some of that. But again, we're 4 people. And I'm sort of the epidemiology expert. So, and it's just me. So if I had to come into work every day and design and disseminate survey after survey after survey, and then hopefully get it collected in an easy way, that's still a lot of work of cleaning data and getting it ready to be analyzed. And that's a lot of tedious work.
And being able so it can be shared.
Right, exactly.
Because you have to have clean data.
You have to have clean data, otherwise it won't work. It'll be outliers and crazy relationships between variables that don't exist.
Oh no, variables. We got into a deep discussion about that yesterday, and I certainly followed half of it. Yeah. So yeah, it's important though that I hear what you're saying. Like we need more almost like manpower behind some of that stuff. And that's why if you're listening and you are an agency that has data already like put together.
At least partially.
Sure. Yeah, Jesse could read through the partial stuff.
I mean, that's the thing is I have the skill sets to clean and analyze data. So even if it's, it's slightly messy or it's in a format that's not necessarily usable, like I can transform that, sure.
Mm-hmm.
And it is tedious work, but it's something that I will do.
Mm-hmm.
So yeah, if you have something or you have maybe an inkling of something, I'd love it.
Call us.
Call us.
Do we need to give the number again? Let's do it. 209
280 5252.
Jesse has extension
3.
Ooh, okay.
Yeah, call me. We'll have a nice conversation. I feel like I had a point. I guess the point I'm trying to make is data as a whole, I think, is a very effective way.
Yeah.
But it's also not easy to get. Mm-hmm. So, and I think we at the Hub Coalition do a great job of putting the emphasis on this data because prevention work has to happen either way. I think if we all sat back and waited for data to be analyzed and places pointed towards the right target areas, we would lose a lot of people along the way. Mm-hmm. It's very much like a crisis. Mm-hmm. So prevention work does have to happen no matter data or not. I think we're in a very privileged position to put emphasis on this data mm-hmm. and point ourselves in a direction that would be the most helpful.
Yeah. And we've got a great coalition behind us. The agency, we are Hub Coalition Porter County. What's that really mean? Yeah, we have staff, and that's mm-hmm. great. It's important. We need to have staff, mm-hmm. us, the 4 of us here. But we're a coalition. That's what matters. Mm-hmm. We have a coalition behind this initiatives, behind the movements, and that's so important because we have people who can come to the table and say, hey, you know what? I have a connection with the main hospital campus here in this community. Or, you know what? I'm with this, and I don't see that occurring within my sector. And mm-hmm. then we can use that to inform, right? Mm-hmm. Or maybe we don't have that data at our fingertips, but now we know, okay, let me dive a little deeper. Let me look in these avenues and maybe pull in some more information that I didn't know existed. Mm-hmm. Also, I love qualitative data.
Oh, yeah.
For me, that's where my heart lies. Jesse mentioned us doing focus groups, and we've been so fortunate. I'm not going to say much because it's still I'm waiting for the very final stamp of approval, but we're fortunate to be moving in the direction of getting some focus groups with youth, and that is going to be killer information.
Very helpful, yeah. I think qualitative data like that is, I think a lot of epidemiology, people say, well, qualitative data is just sort of a means to focus your quantitative data. But, and while that is true, qualitative data, I think, also helps you hear from a community, hear from a section of people, and a community knows itself best. Mm. So, we can take that qualitative data. Why do you use substances? Where did you get them from? That kind of thing. How does it make you feel? That sort of informs a lot more than some statistics could. So,
mm-hmm. and I think when we're in prevention, one of the phrases you hear once you enter the prevention world, and I don't know if it'll ever go away, probably not, but nothing about us without us.
Yeah, exactly.
So focus group is like the essence of that, right? Like we know what the data says in a quantitative data way. Now we're going to take that qualitative data and make sure that we're kind of mirroring or mm-hmm. needing to learn where we need to direct mm-hmm. differently. So I'm really excited about those focus groups because we're specifically hoping to get some information about marijuana use among youth. Mm-hmm. And I think it will open our eyes to one, if our main data source that is like our youth data source is seeming to be aligned with that, mm-hmm. Or if it's slightly different. And so I'm interested to see what the outcome of that is, if we're seeing like similar trends and if it aligns. Mm-hmm. Yeah, hopefully it does.
Well, I'm interested for that too. Is hopefully when this gets up and going, we can find out sort of trends in procurement of substances. There's barriers for kids to get alcohol, to get marijuana mm-hmm. because it's illegal for them, but we know that they're getting it. Mm-hmm. if we know how, I think that highlights an idea of, well, maybe we can change policy. Maybe we can intervene in that certain sector and mitigate a lot of the problem.
Yeah.
And that's something that statistics won't tell you mostly, or at least the data sources we currently have won't tell you, because a lot of those questions, it's such a nuanced question to ask, where do you get your substances, that it's almost not worth asking in like a paper and pencil survey, in my opinion. I mean, ideally people do it, but
well, right, yeah, well, right. And then you have like the, I think, like, to me, I don't know, I perceive, and maybe I'm wrong, I haven't really asked any of the youth that take the survey because it's anonymous. So, but my perception is that when they take a survey, they probably feel it's done in the school setting. So they're probably a little nervous to check anything that indicates use or procurement and then turn it into an adult.
Right.
So I wonder if that will shift. I don't know if we're going to be able to reduce those barriers because we're adults asking questions, but I'm hoping, the cool thing about doing something like a focus group is the idea is that you get to build a little bit of rapport.
Right.
So they feel comfortable sharing things that maybe they wouldn't feel comfortable just checking a box on a piece of paper, going to what they're probably assuming is the principal or something.
Right. Well, and I mean, that highlights a barrier to any sort of survey in general, is that when we do surveys, we assume people tell the truth, and that's it. And that's not like a unique Porter County problem. It's not a unique Indiana Youth Survey problem. It's a survey sort of staple. And that's why it's always considered a limitation in any sort of scientific epidemiological study. And that's it. And that's just fine. I think if we take it in good faith, that's what we have to do. Yeah.
I would like to, the one thing I was kind of thinking that I was hoping you might illuminate just a tad on, because we're coming short on time.
Okay.
Is if you had like the dream, if you had exactly how you'd like things to be done in terms of like community collecting data, what would that look like? And how can our community partners help push that in the direction we're looking for a little bit?
Yeah, I think so. One of the big things is while we do have the Indiana Youth Survey, I do think that there is an underrepresentation of adolescents who even take the thing. It was only in 2022, it was only in a handful of schools. And while I think it was a sizable sample, it was only a fraction of the population. So I think number one is, ideally every student in the county takes the Indiana Youth Survey, and I think a lot of that comes from a lot of moving the needle in the direction of doing that is making partnerships with these individual school systems, at least, and sort of convincing them the need for it, because I do think it does put a lot of pressure on the school to, especially with the new survey laws, it puts a lot of pressure on the school to do a lot of this front end legwork. So, and our teachers and administrations are so busy anyway, I think they just decide, well, if we don't have to do it, we're just not going to do it. So there's that. And then I think when it comes down to maybe a sort of an adult population, I'm not sure what my ideal would be. I think if we could, what I would really like is to be able to stratify the data more. I think every statistic that's on any of these dashboards, or from like the coroner's office or from any police department that we get data from, I think if we can tell age and sex and maybe even sexual orientation, I think that would help illuminate a lot of trends to make sure that, again, people aren't falling by the wayside. I just had another thought. I think it'd be really nice to see sort of breakdowns of who is in recovery. I think that might help help us grasp a picture of what types of people, meaning, age, sex, that kind of thing, what types of people are seeking recovery and what types of substances were they using? What kind of substances were they using together? I think that would help a lot. I think that comes from pushing, again, the needle towards, if you're maybe a private entity, or if you're a recovery center or a recovery home, being willing to at least come to the table and have that conversation of what is your population like. And in a real sense, I think if we have the time and the manpower, I think from there we would be able to survey them directly from our coalition staff, like creating a survey to highlight any gaps that we have or questions that come up. Just to go in and say, will you distribute this to the population, and have them return it and have that information willingly available. And that's a lot of work. And I don't know.
Epidemiology work group, anyone? It's a lot of work.
So yeah, it's a lot of stuff, and the data we have is good. I think it points in. It captures a lot of the trends that I think are enough, at least currently, to drive our interventions directions.
Hey, we're doing the best we can.
We're doing the best we can, and yeah, we do a lot.
Yeah, we do, and I, not to. We've talked about the ways we'd want to increase things, but like you said, we are pulling in enough data to really inform what we do. So, we're doing a good job, but, as you said earlier, more data is never a bad thing.
Right. Well, yeah, and that's ideal. And that's the magic world of magic data collection that doesn't exist.
Just, a little wand in the air, and there it is.
Right. And I do think a lot of these dashboards and publicly available data sets, they definitely capture at least like our adult population more representatively than the youth, for example. And I think if it was a game time decision, or if I had to have one or the other, I think we would definitely want to increase our participation in these youth surveys.
Yeah, for sure. Yeah, I think there might be monitoring the youth, which I think is national, and then there's Indiana Youth Survey, which is state.
Yeah.
And the good thing about Indiana Youth Survey is it does break down to county level. So
which is good.
Yeah, you do get a clearer picture of your county if everybody participates. But yeah, so we're gonna head off here in just a second. But I wanted to bring up two stats that you brought up today that I just thought were like really kind of eye-opening and important maybe for people to hear. First one, we're seeing a rise in stimulants, specifically cocaine. With the assumption that it's being paired with fentanyl, because in our coroner's report, we're seeing that that's oftentimes a comorbidity. Yeah. I don't know if you want to expand on that, but the other one I'd like to mention, and if you'd like to expand on any of these. Sure. I thought it was really interesting where you talked about how we're seeing substance use, I think it was in alcohol. We're seeing it be kind of a larger concern for 30 to 40 year olds. Yeah. Let's start with alcohol. I have a cheat sheet here. Yeah, I love a cheat sheet. So when we look at, this is data from, I believe, the Indiana Drug Data Dashboard. I can't remember the name off the top of my head, but it's maintained by the state of Indiana. And if you look at the breakdown of what I was using was alcohol arrests. Specifically, and as you can see in 2018, the majority of them were between the ages of 15 and 24, and then I believe it's 25 to 35, 25 to 34, excuse me. So in 2018, 2019, 2020, they are by far the leading group in alcohol arrests at any rate. And then as we move towards 2021, 2022, 2023, the shift is from less from the 15 to the 24 and more towards 25, 24 and 35, 44. And
we see that too. I get data from the Portage Police Department, and it's still under review. So maybe take this with a grain of salt. But looking at it and doing some initial analysis of it, you can see that again, a majority of the arrests, or at least police encounters, are for alcohol-related things, mostly operating while intoxicated, but also public intoxication and domestic violence associated with alcohol use. But if you look at those breakdowns, it's often in between the 30 and 40-year-old range versus what you would not necessarily assume.
Yeah.
Or maybe it wasn't the same, 5 years ago.
Right.
So I thought that was an interesting trend, and it's something I think we should be watching for sure.
Because I'm curious, like where. I know you don't have this history, unless you are magic. Maybe I'm not sure.
Maybe.
But I'm just like, okay, so where was that group of people that in that age range?
Right.
What did that look like for them 10 years ago? Were they still at the higher level than, say, 30 to 40-year-olds then, or youth then? It's kind of like, is this a pattern or a trend that's following this specific cohort of age,
people? Yeah.
And I'm like, that's just kind of interesting.
I think it is interesting, and there's a lot of factors that could go into it.
Yeah.
But I think when we break it down just by age, it's really interesting to see that. Yeah, the proportion, especially of 25 to 34, is increasing, and I'm not sure if significantly, but it is increasing quite a bit, and so has the 35 to 44 range. Wow. Which I think is interesting. Now, and moving on to, so if you look at number of fatal overdoses involving stimulants, and this is data from, I believe it's the Next Level Recovery Data Dashboard, which is a state-maintained dashboard. If you look at the rate of fatal overdoses involving cocaine, it's been increasing every year since 2016 to at least 2022. Now, it may have decreased in 2023, and it might be decreasing still in 2024, but that data is still provisional, at least from the dashboard. So I wouldn't want to make a call either way yet. But yeah, you can tell that it's risen from, it looks like from about 3 in 2016 involving cocaine to about 14 involving cocaine. And when you look at our coroner's report that I received, a lot of the cocaine deaths are also implicated along with fentanyl. So I think nationally, and again, don't quote me on this, but nationally, I think a lot of overdoses are shifting towards a stimulant plus fentanyl. And that might be because of how the drug is manufactured or how it's produced by those who are selling it. But that combination of stimulant plus fentanyl is a big trend in fatal overdoses. And you can see that in Porter County, at least, especially fentanyl deaths. I think I have a statistic here where, if you look at fatal overdoses with fentanyl involved, it spiked up from 2019 to 2020 and then from 2020 to 2021. And it has decreased from 2021 to 2022, which maybe the rate is settling back to sort of a baseline, or maybe it's actually decreasing. It remains to be seen. Yeah. But a good proportion of these overdose deaths in Porter County, at least according to the coroner, are involving fentanyl. So and I think that's kind of shifted where if you look at 2018, the rate of heroin and fentanyl was still higher, but they were much closer than they were now. And yeah, I think that's a trend to be on the lookout for too. Yeah,
we definitely need to keep our eyes open, make sure we're paying attention.
Right.
Are these stimulants going to continue to be linked into these fentanyl overdoses?
Right.
Because then that tells us as a coalition where we need to focus our efforts.
Right. If we're seeing fentanyl deaths increasing and increasing and increasing still, maybe we put more education effort into, even stimulant use, which is not necessarily a high proportion of the drug use in Porter County, but it's associated with a lot of death.
Exactly.
Or we push, fentanyl testing in harm reduction activity. Test your drugs and make sure they don't have fentanyl in them, and then that might, help us reverse the increasing of deaths.
Yeah.
Or push our naloxone boxes and say, have this on you, and you may be able to save someone's life, that kind of thing. So that's kind of an example of how the data, I think, is informing the action we take in the county.
Absolutely. Well, with that, Jesse, I think we're at the end.
I think so too. I could talk ad nauseum. So
I really appreciate you, spending some time chatting today with me and informing our community a little bit more about what's going on. And explaining what an epidemiologist is, because almost every time I'm like, "Oh, Jesse, you're an epidemiologist," people are like,
"Yeah."
What?
They say, "Are you a skin doctor?" The answer's no.
It's a no.
No.
So I appreciate you giving me some time today. And for those of you listening, if you are interested in connecting with us for our coalition efforts or getting in touch with Jesse because you're like, "Hey, I have a great data point I'd love to share."
Right.
Reach out. You've heard the number 219-280-5252. Or you can just hit up our website, which is hubcoalitionpc.org, and our emails will be listed there. So thanks for listening.
Thank you.